Syndromic craniosynostosis represents one of the most complex conditions in craniofacial medicine, combining abnormal skull development with genetic, neurologic, and systemic involvement. During normal fetal and postnatal growth, cranial sutures remain open to allow the brain to expand. When one or more of these sutures fuse prematurely, skull growth becomes restricted and compensatory deformities develop. While craniosynostosis can occur as an isolated finding, a significant subset of patients present with additional anomalies affecting the face, limbs, hearing, vision, airway, and neurodevelopment. These cases are classified as syndromic craniosynostosis and often reflect underlying genetic mutations that disrupt embryologic bone formation. Identifiable genetic mutations account for approximately 15 to 30% of all craniosynostosis cases. In this video, we will explore the most clinically relevant forms of syndromic craniosynostosis, including Apert syndrome, Crouzon syndrome, Pfeiffer syndrome, Muenke syndrome, Saethre, Chotzen syndrome, and craniofrontonasal syndrome. For each condition, we will review its definition, characteristic clinical manifestations, genetic etiology, diagnostic approach, treatment strategies, and prognosis. By the end of this discussion, you should have a clear framework for recognizing these syndromes, understanding their underlying mechanisms, and appreciating the importance of early, multidisciplinary care in improving patient outcomes. Apert syndrome is one of the most severe forms of syndromic craniosynostosis. It is classically defined by the premature fusion of the coronal sutures, usually bilaterally, combined with complex syndactyly of the hands and feet. Clinically, affected individuals present with brachycephaly, midface hypoplasia, and ptosis due to shallow orbits. The hands and feet demonstrate characteristic mitten-like or spoon-shaped syndactyly involving both soft tissue and bone. Additional features may include dental crowding, hearing loss, airway obstruction, obstructive sleep apnea, and variable degrees of intellectual disability. Apert syndrome is caused by autosomal dominant mutations in the FGFR2 gene, most commonly the SER252TRP or PRO253ARG substitutions, with the majority of cases arising de novo and showing an association with advanced paternal age. Diagnosis is based on clinical examination, cranial imaging demonstrating bicoronal synostosis, and confirmatory genetic testing. Management requires a multidisciplinary approach, including early cranial vault remodeling, midface advancement procedures, surgical separation of syndactylous digits, and long-term monitoring of neurodevelopment, vision, hearing, and airway function. Prognosis depends on disease severity and timing of intervention, but with appropriate care, life expectancy is generally near normal. Crouzon syndrome is characterized by craniosynostosis associated with distinctive craniofacial abnormalities in the absence of limb anomalies. Patients typically present with premature fusion of the coronal and sometimes sagittal sutures, leading to abnormal skull shape, midface hypoplasia, and ptosis. Hypertelorism, a beaked nose, dental malocclusion, and hearing loss are common findings. Increased intracranial pressure may develop as a result of restricted skull growth. Crouzon syndrome is caused by autosomal dominant mutations in the FGFR2 gene and often occurs sporadically. Diagnosis relies on characteristic clinical features, imaging studies demonstrating cranial suture fusion, and genetic confirmation. Treatment focuses on surgical correction of craniosynostosis, monitoring and management of intracranial pressure, and midface advancement when indicated to improve airway and ocular protection. Most individuals with Crouzon syndrome have normal intelligence, and the overall prognosis is favorable with timely surgical intervention. Pfeiffer syndrome is a genetically heterogeneous craniosynostosis syndrome distinguished by the combination of craniosynostosis and broad, medially deviated thumbs and great toes. The condition exhibits significant clinical variability and is traditionally divided into three subtypes. Type 1 represents the classic, milder form and is associated with relatively normal neurologic development. Types 2 and 3 are more severe, with type 2 often presenting with a cloverleaf skull deformity. Common clinical features include coronal craniosynostosis, midface hypoplasia, ptosis, partial soft tissue syndactyly, and airway compromise. Pfeiffer syndrome is caused by autosomal dominant mutations in FGFR1 or FGFR2, with more severe forms frequently resulting from de novo mutations. Diagnosis is based on clinical examination, radiologic imaging, and molecular genetic testing. Management typically involves early cranial vault expansion, aggressive airway management, midface advancement, and supportive care for associated complications. Prognosis varies by subtype, with type 1 patients generally having good outcomes, while types 2 and 3 carry increased risks of neurologic impairment and early mortality. Muenke syndrome is the most common form of syndromic craniosynostosis and is most often associated with unilateral or bilateral coronal suture fusion. Clinically, patients may present with facial asymmetry, brachycephaly, or macrocephaly, and a high prevalence of sensorineural hearing loss. Limb anomalies, when present, are usually mild, and cognitive development is often normal. Muenke syndrome is caused by a specific autosomal dominant mutation in the FGFR3 gene, known as the Pro250 mutation, and exhibits variable expressivity even within the same family. Diagnosis is established through clinical assessment, cranial imaging, and targeted genetic testing. Treatment is individualized and may include surgical correction of craniosynostosis, audiologic monitoring and intervention, and developmental surveillance. Prognosis is generally excellent, with most individuals leading normal lives. Saethre, Chotzen syndrome is a relatively mild craniosynostosis syndrome characterized primarily by unilateral or bilateral coronal synostosis and facial asymmetry. Distinctive clinical features include a low frontal hairline, ptosis, small ears with a prominent crus, and partial syndactyly of the fingers. Some individuals may have short stature or mild learning difficulties, although intelligence is often normal. The syndrome is caused by autosomal dominant mutations in the TWIST1 gene, which plays a key role in craniofacial development. Diagnosis is based on characteristic physical findings, imaging studies, and genetic confirmation. Treatment typically includes cranial surgery to correct skull shape, surgical correction of ptosis when necessary, and supportive therapies tailored to the patient's developmental needs. The prognosis for Saethre, Chotzen syndrome is generally favorable, with good functional and cognitive outcomes. Craniofrontonasal syndrome is a rare genetic disorder notable for the paradoxical observation that females are more severely affected than males. The condition is defined by craniosynostosis, usually involving the coronal sutures, combined with marked hypertelorism and a broad nasal root. Additional features may include facial asymmetry, cleft lip or palate, skeletal anomalies affecting the ribs, clavicles, or digits, and variable intellectual disability. Craniofrontonasal syndrome is caused by mutations in the EFNB1 gene and follows an X-linked dominant inheritance pattern, with greater severity in females due to cellular mosaicism. Diagnosis is established through clinical evaluation, imaging, and molecular genetic testing. Management often requires staged craniofacial surgeries, orthopedic interventions, and long-term developmental and educational support. Prognosis is variable, but many patients achieve good outcomes with appropriate multidisciplinary care. In conclusion, syndromic craniosynostosis encompasses a diverse group of genetic conditions that significantly affect craniofacial development. Although these syndromes share the common feature of premature cranial suture fusion, each has distinct clinical, genetic, and prognostic characteristics. Early diagnosis, precise genetic testing, and coordinated multidisciplinary management are essential to reduce complications, guide surgical planning, and provide accurate genetic counseling for affected individuals and their families. If you like this video, follow for more genetics made simple.